This week on the Backtable podcast. This is one of my favorite ones because it has the highest percentage of 0 out of 10 post-pain scores. So I love that aspect of it personally.
It truly is. It's a procedure that once you put it in your practice is difficult to get rid of because it's so useful if you know where you're going and the treatment options. It is, in my opinion, a very one of the essentials procedure to offer within a serious pain practice.
Hello everyone, and welcome to the Backtable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on backtable.com. Today's episode is part 2 of my discussion with Dr. Clerk about degenerative disc disease. If you haven't already, check out part 1, which is an introduction to degenerative disc disease. Today, we're going to revisit backtable basics, and we are focused entirely on the technique of lumbar disc access for this episode. And so let's talk about what the audience has been waiting for, salivating for maybe. But actually, let's just talk about the technique of lumbar discogram. This has become one of my favorite procedures to do, very satisfying from a technical aspect. So why don't you walk us through fluoroscopic guided discogram?
Yeah, so there's 2 ways to really access the disc. I mean, the most widely known technique is passing through the Kambin triangle. So basically, Kambin triangle, you have the roof that will be exiting nerve. You have the TP, or the superior end plate of the inferior vertebral body, and then you have the lateral portion of the superior articular process. And you're passing through that triangle, and obviously you want to avoid that exiting nerve. So you need to be able to align those end plates really perfectly to have really that clear space. And once you do that, you bring the needle down up to the superior articular process, and then rotate 180 degrees your bevel to puncture through the posterior annulus. So very short, very easy way to access the disc. There's also a far-lateral approach. So if you want to use a very more oblique technique, you can pass actually above the exiting nerve root that, can be utilized for larger implants, for instance, or if you will really want to have almost this trans-psoas approach to position something very centrally within the disc. But I would say 98% of the case that we're passing through the Kambin triangle. It is a great anatomical region to work with to give access to the disc.
Yeah, absolutely. Kambin's triangle is probably one of the most, to me, amazingly consistent anatomic features, because no matter how small that foramen is, you always know that the exiting nerve root is going to be further away from the corner of the SAP. And so I found if you just hug that right angle of the SAP and the TP or end plate, then you'll stay safe of the nerve root. And of course, we're using 22 gauge needle for the most part, at least me. And even if you touch the nerve, the patient will let you know. No harm done. Just don't go further with that. Realign your needle, and you'll find that invariably you're too far lateral.
Yep.
And so once you get into the disc, usually the patient feels a bit of a twinge passing the annulus, especially if the disc is indeed painful. That's one reason that I find this procedure more than any other. I do recommend sedation. I've had a handful of hardy patients who said, I'll do it with just local. And even the toughest of the tough Oklahoman farmers who've done that afterwards tell me, yeah, that hurt. So that can be a bit tender, getting through the annulus. But then once you're through, and of course, so we start off with that oblique view to line up Kambin's triangle. And then there's definitely a significant tactile feel to the annulus, even one that's very degenerated. And so once you get that, then you can switch to a lateral view and assess your depth. And like you said, we want to get into the center of the disc, especially for certain implants. But once you're into the center of the disc, and you can check your AP to make sure if you like that, what are you injecting for your contrast, your actual discographic agent?
Yeah, just Omnipaque 300, just nothing too too fancy. Yeah. So that's to me provide good contrast and is pretty. And normally I inject also under live acquisition, so I can assess directly and in live fashion if there's a pain response whenever the contrast migrates toward a tear. And this has been also quite insightful to see what cause pain in patients. Those tears are just very painful for patients. Sometimes you miss them on MRI, and whenever you inject that dye, you see that horizontal tear that will migrate toward the outer annulus. This confirms the pain generator. So this is another step that I'm doing, but doing the AP, the lateral views are the classic views for the discogram, and more again using CT to really understand the anatomy there. Not required for all patients, but definitively if you're thinking of injecting something permanent within that disc.
Tell us about the actual injectate that you're using. So first of all, about how much contrast do you inject?
I would say it varies from one disc to the other. You can inject between 0.5 cc to, theoretically, you could inject up to 5 cc. In some discs that are collapsed, that you have vacuum cleft, you can really fill those discs. You understand really the void of substance in those degenerated discs. So it is, I don't have a absolute number that I'll use for a discogram. It is more something that I inject, and I either obtained serial fluoroscopic spot, or I use live fluoroscopy to be able to determine when to stop when I'm injecting the contrast. But yeah, it fluctuates from one patient to the other and one disc to the other because of the degree of degeneration.
Yeah, it does vary so much. And I find a young patient with a single symptomatic level, a lot of times injecting literally 0.25 cc's is enough to get a response.
Oh, yeah.
And and I find that honestly, in terms of the contrast, that if you, as long as you get some in there, if you follow it up then with your injectate, which I always use the anesthetic and dexamethasone, then that plumps up the volume too, but you still have that effect from the contrast, which has now just been, diluted by the other things that you put in there, but is still this liquid, which is diffusing into the annular fissures and such. And so in your typical day-to-day discogram practice, do you perform purely diagnostic anesthetic discograms, or do you always add steroid as well? And what are you using for the anesthetic?
So it depends what I plan to do. So if I plan to select the patient for a clinical trial or for a subsequent treatment, I may just use 2% or 4% lidocaine and just do that diagnostic test, anesthetic test, to determine if this is the pain generator. If we're planning to treat someone that is not a candidate for a clinical trial or any other treatment, I'll probably use dexamethasone in those patients, and they will do well for a long period of time. It depends what's the end goal, and this is discussed with the patient, and depending where they are at and the degree of this degeneration also. I try as much as possible to avoid corticosteroid in younger patients, obviously. So those patients that, will go more toward the PRP route whenever indicated, or now we have other type of injectables also. I know that you talked in the past to other colleagues about the VAST trial, right? So micronized nuclei proposi. That is also another very interesting technology with great result and great decrease in ODI and VAS. And now we have another clinical trial that is another system that is called the Discography system, which is basically a spinal cord stimulator that the lead is positioned within the disc. So it is, now we can do an electrical stimulation of tissue healing. So we can potentially regenerate some of the tissue. So that's another way that we can treat discogenic back pain and potentially reverse even some of the tears and some of the degeneration. So in those cases, we don't want to inject any type of corticosteroid. Those will be patients that have earlier onset of this degeneration and with a specific purpose.
speaking of CT, what you just said got me thinking of something else for our radiology colleagues who are listening. I would say that actually this, more than any other that I can think of, this injection, I think is significantly harder, if not sometimes impossible, under CT, but consistently doable under fluoro. And so I will say a lot of our radiology colleagues, ironically, have greater availability of CT for procedures than a C-arm. I would say for them, discography is very difficult under CT, just because the axial projection is very rarely going to respect your gantry. And that's why the first step in the discogram is aligning the end plates, like you said.
Yes.
So just one thing I did want to throw out, but also getting that extra element of the CT to actually be able to look at the three-dimensional nature of the tear, I think is so interesting. And I think this makes total sense. It's a bit like an arthrogram. It really is an arthrogram, I guess, if you think about it that way.
It is.
And so you get so much information from this. You can kind of give a qualification of the degree of degeneration on fluoro, CT if you have it, and then talking about the patient's pain response, if they had a concordant pain response when you inject, and then what their pain response is afterwards. So we always get a pre and a post pain score. So the pre taken at the time of workup, and the post, we would take that usually around the time they're leaving once they've woken up from sedation. And this is one of my favorite ones because it has the highest percentage of 0 out of 10 post-pain scores. So I love that aspect of it personally.
It truly is. It's a procedure that once you put it in your practice is difficult to get rid of, because it's so useful if you know where you're going and the treatment options. It is, in my opinion, a very, one of the essentials procedure to offer within a serious pain practice. So agreed with your comment about fluoroscopic guidance. This is totally the easiest way to do it. Sometimes I will use CT scan, but I do agree with you. Sometimes the patients with a quite accentuated lordosis, at the L5S1 level, it's a little bit tricky. Go-to is definitively under fluoroscopic guidance. In very thin patients, you can use, and I've used in the past, ultrasound. You can use it, but after that, for your views, it's a fluoroscopic procedure, I think, in the majority of cases.
Absolutely. And as you're saying, that reminded me of some of the other tricky situations to get into the disc, even under fluoro. And so you do enough of these, you'll find the ones that are really tough and they really make you figure things out. And I think probably the most difficult is a borderline grade 2 spondylolisthesis with a collapsed disc space. Usually the disc space is pretty collapsed. Sometimes it's not quite, but still very difficult. What has been your strategy to approach those discs?
Yeah, so know your anatomy and provide more cranial angulation because you'll need it. So again, align your end plate properly, bend your needle tip. Often you can use a larger gauge needle. So, I will migrate up from a 22 to a 20, sometimes even larger than that. And you can even drill through the end plate. So I'm doing that a bunch of times for those a bit more difficult patients. It's extremely rare that you cannot access the disc space. Often it's aligning your end plates, making sure your trajectory is parallel to your disc on the lateral view, and then advancing slowly. So we do a ton of those procedures per year. And I can't recall the last time that I was not able to access the disc. It's even in those, grade 2, grade 3, you can. And then your last resort is always passing through the pedicle, right? You can always use a transpedicular approach. So basically, just like if you were to do a kyphoplasty, pass through the pedicle of the superior end plate of the inferior level and position the tip of your needle superiorly. So, and it will arrive exactly in the center of the disc. So we do, for instance, occasionally discoplasty that way. You put a balloon, inject a little bit of cement. So that's something that you can, another trick that you can have in your toolbox.
That's fantastic. I haven't gotten to do the transpedicular access yet, but I look forward to it. And one of the things that Dr. Beal taught me about these very difficult spondy cases is, like you said, you need more cranial angulation. And so bending the needle, I think, is crucial. So always about a 15 degree angle coincident with the bevel at the end of the needle, and allows you to steer in a curvilinear fashion that helps you get around these tricky spots. And so starting actually with your height a little bit more up towards the inferior aspect of the pedicle gives you a little more of that running room to get under and then into the end plate, which of course, since you slipped forward, it's just a little trickier. And then you refer to drilling through the end plate, and I think that's one of those fundamental things you just have to get comfortable with is you often get caught on an osteophyte. And a lot of times you see these osteophytes that I'm just like, oh my gosh, the guy, they're almost auto-fused, and yet you can't really see that well much of the time on MRI. And so if you have a CT beforehand, it can give you a little more information that you may have a little trickier time. But just knowing basically this drilling technique, for anyone who hasn't done it, when you have the angle at the end of the needle, you can just kind of twirl the needle back and forth in kind of a sort of corkscrew fashion, not turning it all the way around, but doing that and applying forward pressure will often get you kind of over the ridge of these osteophytes, or even allow you sometimes to, in a disc that's kind of starting to auto-fuse, where the osteophytes are actually coming together, you can actually punch through that. And we actually had to do that somewhat recently at the Seattle Science Foundation course, where the cadaver that we got was, as you said, it was, looked like your average patient with basically all their discs auto-fusing together. And so in that case, that's one of the few situations where the 22 gauge needle is just not going to cut it, because it will just deflect off. And that's one of the few places where, like you said, you go up a level. And in that case, we were in a laboratory setting. And so I would not recommend anyone do this right off the bat. Wait till you're more comfortable to use the more rigid 18 gauge needle, but it can certainly come in handy.
Yes. And
you can literally drill. I mean, you can literally hammer it in. There's very few situations, I think, where you need to have to do that. But disc access is one of those things that, like you said, there's almost never not a way to do it.
Absolutely. And it's not infrequent that we'll use an 18 gauge needle for that. And 18 gauge, you can pass through bone. We use that very frequently for even passing through the lamina to access directly, for instance, facet joint ventral synovial cyst, to aspirate, rupture, fenestrate them. So those needles are good. You can pass through a true bone fairly easily. It's not their primary use, but if you're gentle enough, but not too much, you can pass through bone.
So outside of the actual technique itself, which I think is one of those things that once you start doing it's really, it's like one of those very simple things like lumbar puncture, where at first you're like, yeah, this is easy. And then you have your first couple kind of tough ones and you learn a lot. And then you just do that over and over again. Once you reiterate on the technique, you'll find just how powerful it is. And so I think this is one of those things that you'll continually get better at. That's certainly how my growth has gone with it. And there's, of course, no shortage of patients. But some of the most important stuff about this procedure, I think, actually relates to what you do beforehand. I'm alluding, of course, to prophylactic antibiotics. And so there's a lot of kind of fear mongering, I feel like, that goes on about disc injections and discitis. And I just find that the research hasn't substantiated that very much, but still always using IV antibiotic prophylaxis beforehand. Would you agree with that?
Completely agree with that. You read the literature and even coming out of the SIS, there's reports that say that, if you don't provide antibiotics, you will have rates of infection between 0.4 and 1.9% of discitis, which is enormous in my opinion. Definitively, you need to provide antibiotics, prophylactic antibiotics for this procedure. But and that's based on the NAS recommendation for this disc access. But there's other countries that are a little bit more liberal on the use of antibiotics or are not providing it. And if you use obviously sterile environment, you clean very well the skin, they have not noted such an increase of infection. So it's interesting that there's geographic differences in how, people think about prophylaxis antibiotics for discogram. Definitively, if you're putting an implant, something a little bit more substantial, definitively this, I would suggest the antibiotics. The NAS recommendation are such that in North America, we use prophylactic antibiotics. This is what I'm doing in my practice. But it's interesting to see throughout the world, there's different ways to think about antibiotics.
So what's your typical antibiotic regimen?
Yeah, so cefazolin, so 1 to 2 gram 30 minutes before the procedure. So I would say 1 gram is pretty much our go-to. And if they have allergies or contraindication, gentamicin or clindamycin. But cefazolin in the majority of our patients.
Excellent. So as we move into the second part of this topic, which is really about what happens after the discogram, let's talk a little bit about your treatment paradigm. So options beyond the disc injection. And I found personally that more than any other joint injection, and I've probably said that about 5 times at this point during this podcast, this lasts very long as an initial diagnostic tool, as a therapeutic intervention. So a lot of times you may not see a patient for another 1.5 years or more. And then they come back and they say, yeah, I just need that injection done again. It can last for a very long time. But of course, those cases where it doesn't, the patient gets a few months out of it, maybe a few weeks. Very rarely have I seen it less than at least a few weeks, but it happens. And then we're in this interesting twilight time where we don't have a lot available, but it feels like we're awaiting a tsunami. So why don't you tell us a little bit about kind of what's currently available, at least that you're using, and allude to some of the other options.
Yeah, so it's a fascinating field right now, and it's very exciting because, as you mentioned, I think we're just discovering the tip of the iceberg, and we're seeing that 80% of the treatments are coming, and they're coming very, very quickly. There's Therapeutic Discogram. You are familiar with this. So the injection of dexamethasone or corticosteroid that can help more severely degenerated disc. There's some good data also that are out there for painful modic type 1 degenerative changes coming out of Europe, coming out of France. That can be an option. Another option that we're trying to move forward with lower grade of disc degeneration is intradiscal PRP. So intradiscal PRP that you can inject also safely, and there's more and more data that demonstrates how good it is. There's 8 quite serious papers that evaluated that between then followed patients from 6 months to up to 2 years. We have now 2 RCTs that evaluated also decrease in ODI and NRS after intradiscal PRP injection and followed patients up to 12 months. And it is a sustained pain decrease. I would say classify in average probably a 40 to 50% pain decrease. That was in their study, and unfortunately they did not even use discogram to be able to stratify those patients. So you probably had some of those patients that had other pain generators that were concomitant, so facetogenic pain in addition to this degeneration. So I think even the results that they presented, although good, could be even better. And currently we're following actually in my practice more than 200 patients that were treated with intradiscal PRP, and some that were following at 3-4 years after injection, they're still doing very good. So yeah, very interesting therapy. Another injectable that's we've seen is BMAC. So a stem cell that can be injected also within the disc. And one of the latest RCT took a look at how patients decrease their pain through time if they were treating either with saline, BMAC, and PRP. And PRP and BMAC seems to be pretty similar in that paper at the 12 months mark. So pain decrease again close to the 50% range. So good interventions. Again, in my opinion, you can probably obtain better results if you're confirming the pain generator confirming the pain generator with an anesthetic discogram or a provocative discogram before you proceed with the treatment.
This concludes part 2 of our discussion with Dr. Clerk. Tune in next week for our third and final part where we will discuss intradiscal augmentation and other future emerging treatments for discogenic pain.
Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @Backtable MSK on Instagram, X, or LinkedIn. Backtable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer. Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.